everyone. This is Dr. Seema Awan, Chair API Board of Trustees. Welcome to another very educative webinar in the API COVID-19 series. Today we will be talking about practical tips for practicing physicians and the financial survival of small practices in COVID series. It's a very important topic as a majority of our physicians are in private practices and can benefit from this. This topic was briefly discussed in the past, but due to popular demand, we are bringing it back again. And Dr. Chakravarti has been kind enough to put this together and has worked very hard putting this webinar together. Now just saying a few words about Dr. Amit Chakravarti. He's a practicing board-certified urologist who's been practicing in his private practice for about 25 years now. And he's also Vice Chair of API Board of Trustees. So please welcome Dr. Chakravarti to take over the moderation of this conference. Dr. Chakravarti.
Okay, thank you. Thank you very much, Seema. I just appreciate you introducing all of us. And I just wanted to thank you. I thank Suresh Reddy because I had got this blog called Financial Tips, which is very important for the practicing physicians, and it's really become popular. And Suresh was kind enough to reach out to me, telling me to have a committee together so we can all speak on this important topic, so that how we can keep our light on, and that's what we're going to do. So I've got an excellent panel of speakers, as you know, and we're going to first start with the financial things like the PPP, the ever-changing rules and regulations of all the financial aid which the government is giving. So let me introduce my speakers. And so first speaker is Dr. Nilagaru. Dr. Nilagaru is a board-certified cardiologist who practices cardiology in Georgia. He's a founding chairman of Quantum National Bank, a 513 million asset bank, currently the 6th most profitable bank amongst all the banks in USA. And he's under the 3 billion category. He has served as a board member for several organizations, including Cigna, Health Springs, insurance companies. He was voted the best physician of Jackson County and given the Lifetime Achievement Award. He has been providing free medical care to the underserved population in the Atlanta area for the last 20 years. With him is his CEO of the Quantum Bank, Dr. Brian Cohen, and he's been associated with Quantum Bank for the last 18 years. He's got a degree of finance from University of Oregon and Masters of Finance in Georgia. And like I previously mentioned, Quantum is a very well-rated bank and has been one of the top community banks in Georgia. And they are an active SBA lender and are very well versed in the PPP program. We cannot have anybody better than both of them to speak today. Thank you. Brian and Dr. Nilagaru.
Let me take a minute and, a few very important points with regard to this PPP loans. The first one is physicians out there, please do not apply for more than one institution. It creates problems for the physician as well as the banks if you apply for more than one bank, and potentially it can be confusing as well as a potential fraud. And another important point is once you get the funds, the bank by law has to distribute the funds in 10 days. If you already know how you are going to get the funds, then go ahead and take the funds. Otherwise, you wait as long as possible to get your funds. 60 days spend it. And it starts from the day your application is approved. Once you get the funds, please open a segregated separate account just for this PPP loan until you are done spending your funds. That way, if the SBA or somebody else were to audit you a year, 2 years from now, you can follow the account very easily and show them the funds and how you spend it. And with that, I want to stop and please ask us any questions. Brian Cohen, our CEO, has the extraordinary expertise in these PP loans. He has approved and disbursed approximately 560 loans so far. And once the gates open on Monday morning at 10:30, we have another 200 applications pending to go through. And I will have Brian say anything he wants to say about the PPP loans. Brian?
Good evening, everyone. I think Dr. Neil gave a good summary of the program. I'm going to back up a little bit and then explain what has happened, where we are, and what Quantum is doing, and how that might be able to help you on a individual and personal basis. The PPP program stands for Payroll Protection Program. It's through the SBA, being managed by the Treasury Department. You really need to think of it, though, not as a loan, but as a grant. The purpose of this program is so that small businesses can keep their employees without having them go be dismissed or go on unemployment effectively until June the 30th. The focus is to allow the economy to stay afloat until things start to get rebooted. Round one went extremely fast. There were $349 million committed in about 10 days. The program is expected to go probably even faster when it gets initiated on Monday. Simplistically, for those of you who have not gotten a loan yet, the idea is you have to provide to your bank the information about your payroll and how much that costs you on a monthly basis. The bank then calculates those costs, and we are able to give you a loan of 2.5 times your average monthly payroll costs over the last year. The money needs to be used 75% for payroll at a minimum. It can be used up to 100%. And the other 25% you can use for other operating costs for your own institution, for your company. The Quantum ended up making $58 million of loans in round one. Round two is starting again on Monday, and it's a little bit like a race. The program that is being opened by SBA starts at 10:30 in the morning on Monday. We already have a backlog of loans that have been approved, and we are anxiously waiting for the program to open so that we can start to input those loans. If you have an existing relationship with your bank, that is the best place to go. However, the large banks have not done a very good job in this program from an overall perspective. Small banks, which make up only 3 or 4% of the total market, have made 20% of the loans. So if you have a good small bank relationship, that may be the best way to go. Another part of the program is also allowing you to get a loan if you are a 1099 employee. The problem is that the regulations have made it very difficult to get those loans as a 1099 employee. You effectively have to have already filed your tax return for last year, for 2019. We have ended up making a number of loans to small doctor practices. We understand the pain that you are in right now and have been pretty efficient at trying to work through the process. When things open again Monday, we already have a backlog that we're going to be working on. We have been focused on people that are customers, but we are also making loans to what I'll call family and friends, and clearly anybody in the medical profession that has been associated with Dr. Neil over the years is clearly a family and friend to Quantum National Bank. There's a lot more details that I could go over. If you are interested and you are a Georgia physician or a Georgia practice, we do have a global email address that we're using, which is ppp@quantumbank.com. We do make loans in other states. Our rule is, however, it has to be within 250 miles of our corporate headquarters, which is in the North Metro area of Atlanta. So that takes us into southern Tennessee, some of South Carolina, and about half of Alabama. But our major focus is in Georgia. And if there's any questions, I'd be happy to try to answer them. The program does seem to change with additional guidance on a daily basis. So anything that you hear or have heard in the past may or may not be the same today. And we could wake up on Monday morning and find out something else has changed. Thank you.
Great. Thank you, Brian. And thank you, Dr. Nilagaru. Like I said, this is the hottest and the ever-changing rules change every day. I've been talking to Dr. Nilagaru. We actually have a laugh about this, that what's going to happen tomorrow, et cetera. But like you said, the second round is here, and please put your applications in. And smaller banks would be better to apply because they have got less amount of applications, and they have a quota which they have, so that may be a little bit easier to get it from smaller banks. And we'll be glad to help. If you want to locate a small bank in your area, I'll just email me and I'll be glad to help. Thank you so much. So let's go to the next speaker. Next thing we're going to talk about telemedicine, because today's day and age, what we are trying to see is to limit your exposure to your patients and yet keep seeing patients. Medicare has laid out very, very flexible rules for doing telemedicine, and it's something which actually saves both patients and actually makes them more comfortable being seen from home, and you can still bill for them. And so I'll let Dr. Mursetti and Dr. Raj Grover take over and talk about this. And let me just introduce them a little bit. Dr. Mursetti is a board certified in internal medicine, pulmonary, sleep, and obesity medicine. He's in solo practice. He's graduated in 1985 from Gandhi Medical College, Secunderabad in Telangana. He's a life member of API and TAPI, and he's married and has one daughter in med school. Rajesh Grover is a successful entrepreneur with extensive experience in developing and maintaining business relationship, and he has co-founded 2 years ago a healthcare company called Chronic Care Management and Remote Patient Monitoring, using an AI-driven, artificial intelligence-driven telehealth app. He has negotiated with CMS, Medicare, Medicaid, and private insurance company. So he's very, very familiar with all the things which are going on, and he also will be a good person to have in this meeting. He is not a physician, but he's actually very knowledgeable with what's going on. So over to you, Dr. Mursetti and Dr. Grover.
Hello, everybody. This is Rajesh Grover. Hi, I've been involved in the healthcare industry for past 18 years. I used to own and operate a sleep diagnostic company, and we had 11 locations in 5 states. So currently I own a healthcare technology company. We focus on chronic care management and remote patient monitoring, which are offshoots of telehealth. So we have spent our last 2 years developing our technology, working with patients, working with doctors, working with their staff, trying to make sure the product is very seamless, it's easy to use, very friendly, and there's a proper flow. And then at the end, the doctors are able to bill and collect money from CMS and insurance companies. So what is telehealth? Telehealth services, they use information and communication technologies to deliver health services and transmit health information over both long and short distances. It's about transmitting voice, data, images, and information while maintaining social distancing, especially in the times such as current. So examples of telehealth services include remote patient consultations, including health education services and remote monitoring of vital signs such as ECG, changes in weight, or blood pressure. Originally, Medicare and insurance companies were paying for telehealth only for the rural areas. But now due to COVID-19, they are paying for services done all over. Telemedicine is a product of telehealth. So telehealth is on the top, telemedicine is at the bottom. Telemedicine is a limited use of electronic and data, but telehealth is a bigger platform, so which covers education and communicating with patients through reminders. So there's a lot more involved in telehealth. So telehealth is a part of telemedicine is a part of telehealth. Sorry. So with telehealth, the patients benefit. They don't need to take any time off. They don't have to deal with the cost of travel or travel delays, and the kids don't have to take any time off from school. What is the benefits for the doctors? The doctors can expand their reach. So now there is no limit from where the patient is coming from or they're communicating with. It saves them time, travel cost. Now the specialists don't have to travel from one office to another office, or they don't have to travel from home to different hospitals. Makes them more efficient. And even for the phone calls, a lot of times before when doctors were calling patients, they were not getting paid. Now, even for the phone calls, doctors will be getting paid for this, for their time. In 2018, Medicare saved over $20 billion under their chronic care management program. And in 2019, they saved $35 billion. So this program works. You just have to make sure that you choose the right product, right company, and it has a good onboarding process. So, the technically, you're partnering with the company who's going to be with you for a long time. So make sure you do your homework, choose the right company, and it has all the bells and whistles. Do your comparisons. There's a lot of companies out there providing telehealth platforms, but make sure you guys do your homework. And I will let Dr. Morissetti speak and give you some more education on telehealth. And I'd like to thank you, Dr. Amit Chakravarti and Api for including us in this discussion. Thank you very much. Dr. Morissetti, please.
Okay. Hello, everybody. I'm going to share my screen so you can see some other, because you don't need to see my face, you can understand. Let me start with this screen here. I divided these into 6 types of visits, basically. When you are doing telemedicine, where can you monetize? How can you monetize all this? We have to be efficient with our time. We have to be efficient with our money making. And we make so many phone calls to the patients, to the families. We report to them labs. We don't get paid for that time. So now at least during this emergency period until the end of June, but I believe after that it will be followed up by modified versions of it forever. So one of the common visits that we always make phone calls and at least make some money out of it is lab result review visit. So if you have to tell them about their lab results, either COVID result or any lab result, you can make some money from it, even for a few minutes. Medicare only pays for maximum of 10 minutes. Even if you spend 30 minutes, 40 minutes on the phone, Medicare will not pay more than 10-minute visit. There are third-party payers who will pay up to 30 minutes. So there are 3 codes. I will show you. I have a spreadsheet of all the codes where you can bill for 10 minutes, 20 minutes, 30 minutes. So three different codes for that. This is only telephone visit. You also can do medication refill visits. A lot of these will be, especially in my practice as a sleep specialist, for narcolepsy medicines, Adderalls, Ritalins, Provigil, Nuvigil. All these are controlled drugs that I have to fill every month because I cannot prescribe for 3 months or a year. So you can make money that, those visits now at least can be made. Now I try to make everything a video visit because that's equal to an E&M code and a complexity code. So we'll talk about that in a minute. Emergency calls, if the patients are calling you, that is a billable service even on the phone or on the, as long as you document it. Once you if you didn't document, you didn't do it. Convert the phone calls into financial calls, and then off-hour calls, which you can do. Most of us are on Doximity. You can use a Doximity phone system that will block your personal phone number and it will give your practice's phone number to the patient. And you can use that way so they are not calling you afterwards again and again. And use that service, and that's free service, and you can bill for that. If you are not in the office, you're not with your computer, not with your office phone, you're on your cell phone, you can still monetize that one. Many times you get no shows, primarily because, especially in elderlies or even in underserved areas, they don't have transportation. Especially in this emergency period, they cannot get transportation. Now you convert those no shows into monetization. So those are some of the 6 areas that I can think of immediately that most people don't consider as billable services. Now, which level of the E&M visit code can I use is one of the questions that one of my friends asked me in this group. Use a lower level of E&M code. Do not use level 5, because that is auditable, because on the phone, it is very difficult to defend yourself saying that I'm doing a very complex visit with multiple issues, multiple problems and all that, and justify a level 5 visit. Level 1 is a useless visit because there's a nurse visit. We don't bill for that. So you're only left between 2, 3, and 4 levels for the E&M visits. And those are pretty reasonably paid and good RVUs for them, and you can make. So I primarily use level 3 because most of my patients have multiple medical problems. And then if you have review of systems included, so you don't depend on SOAP. SOAP always underestimates your visit because SOAP misses review of systems, and without review of systems, you will undercode. This is for general, any visit, obviously, not just the televisits. So always include a line. In my state, Ohio, we can say 10 systems reviewed, and that's enough. But other states, you got to say every system separate, some states. So the same rules carry forward even on the video visits. Some of the myths that people have: patient will stop coming to the office if I start doing the televisits. Not true. They still want to come. They hate the televisits. But in a certain situations where I'm between patients, I got out of one patient and the other patient, there is a gap, I can make a video visit in between, and a busy practice, I can still do that. I will earn some additional money. Lower practice revenue is what people think, but that is only if you have all your practice, all televisits. Yes, because you cannot bill higher level of codes, you may lose for the time per hour basis some money, but you're not doing that all. What we are trying to do is maximize the free time or the normal calls that we are converting them into monetized versions of the calls. Patient will demand only televisits instead of face-to-face visits. This is similar to the previous one. Not true again. Most patients still want to visit you face-to-face. Only if they cannot, then they would do the televisits. Especially those visits which are only requiring refills, and they have to wait in your waiting room for an hour, and it will take up so much of time traveling, commuting, and all that. Those. But any visit which really requires your physical presence, they will come to you. That's in my practice, my experience. As I told you in documentation, do not just rely on SOAP visits, SOAP documentation, add review of systems to it. That increases your level of care. Billing, again, we talked about it, usually E&M plus a modifier of 95, and place of service is 02. Medicare and private insurances are paying right now, but in future, the private insurances were not paying before this emergency. We are hoping they will continue. During this emergency, everybody is paying. Prior to this emergency, not all states were covering for these, but right now they are, and we expect them to continue to cover. Okay, and let's go to the next one. Are you able to see this flow chart? I'm not sure if you are. Can somebody tell me? Okay, I added that on here. So
we cannot see the flow chart. Can you just finish in the next minute or two, please?
Yes.
We'll have plenty of time
this
for
flow chart gives you
questions.
how to address which calls do you make, because there are 4 things that I want you to understand. There is a telephone call, there is a video call, there is also a chat which can be monetized, there is also a virtual visit and virtual call and virtual check-in. So there is another feature that most people don't know is in the virtual calls, if I am a primary care, I'm with a patient, and I want to talk to a cardiologist, a psychiatrist, psychologist, some consultant, I can add that physician onto your group call. You can have a three-way call with the patient in front of you or on the call, myself, and add another physician and get a consultation, especially if they are established patient with the cardiologist or whoever you're talking to. That cardiologist can bill, I can bill. So most people don't know that you can do that. In future, even without the patient, if I'm consulting a consultant, I can bill and a consultant can bill without the patient, but that is not here yet. But presently, if the patient is on the call, you can add a second provider to it and the both of you can bill for it. The ones who cannot bill are your therapists. If you have a therapist in the office, you cannot bill for it. Only DOs, MDs, PAs, nurse practitioners can bill right now. And I mean, I got a lot of COVID billing, but one of the things I wanted to forward these later on to Amit, and he can forward to everybody these printouts, is this one chart I want to show you. How you can
that flow sheet and stuff like that is not coming up. So what we can do is maybe when the question and answer comes, you can have that slide up and we can review that again.
Sure, no problem.
Because the flow chart is very important, that one, and the list of codes. So thank you, Dr. Morsetti. That was great. And he has covered a lot of things. Actually, the telehealth part, telemedicine part of it is can be a whole 1 hour talk. There were a few questions very briefly. Somebody said they're only paying 50% for telehealth compared to the office visit. That's the reason you have to have video. If you have audio and video, you can bill the complete code, the exact E&M code for established patient, and also you can bill for new patients.
Correct.
People will ask you how can you bill for new patient, because physical exam is a big part of it. They actually are saying that you can bill for new patients and use the code based on complexity of service, medical decision making, MDM. If your MDM is high, you base your code 203 to 205, 99203 to 205, or 202 to 204, based on the medical decision making, not the physical exam. So that's what Medicare has done. So those are the two things you need to know, and they are paying exactly the same amount of money as your personal visit. Now, telehealth is where you do audio only. There is no video for some reason, and I have got a lot of patients who don't have internet service at home, and they cannot just do a telemedicine. You can do telehealth, and that telehealth will pay only 50%, they'll pay less. So that's the reason you should do video as much as possible. And then there are other codes, like he said, G2012 codes, where the patient actually calls. If the patient calls and tells you that, hey, doc, you know what, I'm having some burning, and you don't want the patient, I'm talking about urology, burning while I pee, and you say, okay, I'm calling in some antibiotic and see how it does. You can actually bill for it because it's a patient-initiated call. And then there are other various calls you can do, which can be paid. And there are some other codes, 99441 to 99443, and those are the codes for telehealth, which pays 50% less, where you only do audio only. And for that, it is only based on time. So 5 to 10 minutes, 10 to 20 minutes, above 20 minutes, there are 3 codes. So anyway, that's a little sum of this. So we will again go back and the place of service. A lot of questions have come over for the place of service, and the answer to that, and I'll have Dr. Morsetti also there. What they are saying is that right now Medicare is allowing place of service to be 95. Your place of the modified 95. You keep your same place of service, your office, whatever office place of service, don't change. Just put a modified 95. And previously there was a little confusion. They had said they said a place of service too. Just wanted to let you know that these days they have said do not modify the place of service. Only put 95 modifier for the time being. After the COVID crisis is over, we may go back to other place of service thing. So again, we'll answer all these questions when people come back. Let's go to the next person here. We are privileged to have my dear friend Dr. Arun and Deborah Stewart from Blue Cross Blue Shield of Florida. And the health insurance companies are also doing a lot, Medicare, of course, and also private payers are following suit. How what they're trying to do is to help you get by this period of crisis, and they have done a lot. And I'm going to introduce these two speakers who are going to talk more about it. Dr. Arun is a senior medical director, provider engagement of Blue Cross Blue Shield of Florida. He was previously the corporate senior medical director of Humana and was the chief medical officer of Aetna. He was, before that, he used to be a primary care physician in Huntsville, Alabama. That's how I know him for such a long time. Also, you might all know that he was the chair of the board of trustees of API. So he's going to talk about so many changes in the health plan has undergone to accommodate the uninterrupted service to its members. And what I'm going to do is have Arun introduce Deborah Stewart, who's actually after he is done, when Deborah comes on, she's a senior medical director of care management of Blue Cross Blue Shield of Florida. And over to you, Arun and Deborah.
Thank you, Amit Chakravarti. Thank you, Dr. Reddy, Dr. Seema Arora, API fraternity, and Dr. Stewart for joining us on this video session. I will introduce Dr. Stewart as I'm finished on my part of speaking. I think the health insurance companies are very concerned about the entire crisis, not only for the the disease itself, the economic impact that it's bringing on practices and providers, and also our members. So we actually meet 2 times a week as a COVID response team, and we spend about an hour. We kind of discuss all the issues surrounding testing and the care management and the bed utilization, availability of ventilators and all that. And Dr. Stewart will talk a lot more about care management. I will focus on other issues, which, if you go to any website, United Healthcare, Humana, or Cigna, or Blue Cross Blue Shield, Medicare, you have that big pop-up showing COVID-19 and how you deal with the current situation. So they want me to speak a little louder. Are you able to hear me better, I guess, now?
Yes, that was better. Thank you.
Yeah.
Thank you.
So so all the websites are talking about COVID, and here is what they have, some of the examples of what they have done. The first thing they realized was because of social distancing, they introduced the telemedicine, and you've heard speakers, Dr. Grover and Maurice Shetty, talk about the telemedicine, so I won't take any deep dive on that. The next thing is, in order to facilitate members using telemedicine, they have removed all constraints. So there is no copay, and you can choose, for example, in Florida Blue, there is a company called Teladoc, which we use, and Humana also has a national company which they use for telemedicine. So most of them are allowing third-party telemedicine vendors to have their virtual visits, and there is no copay for the members. So this also provides opportunity. Previously, there were some restrictions on, crossing the state lines, and those things have been waived currently. And this starts with CMS too. CMS is encouraging, because of social distancing, all the telemedicine visits. So,
Arun, louder. Can you speak a little louder? Yeah.
Okay. The next point is all the testing and all the care that members are receiving for COVID. It started with Humana and Cigna. They have waived all the copay and deductibles. So many other insurance companies have followed suit, including United, Blue Cross, and other major insurance companies. So what happens to those without any insurance? I think you heard President Trump say that those who don't have insurance, the federal government will take care of their bills in the hospital for COVID. So it's helping these members not to get additional stress from what they're already going through. The other important aspect of this is the social determinants of health. Many of the seniors who are actually living on their own, not in residential homes, have had meals supplied to them or other, supporting issues, daily living, delivered to them at their home. So many health insurance companies, including ours, are having that program called the Bold Goal for Humana, and ours is a food insecurity program. We are currently delivering about 1,600 members with food daily to seniors, and it's being prepared at our cafeteria where we used to have our lunches and make sure that those workers are not laid off. They are all third-party vendors. So there are a food assistance program like that. Next is the refill. The medications are extended till 90 days. There is no constraint on the 30-day refill requirement, and this applies for all health plans. And they have removed prior authorization. They have relaxed the rules on many of the procedures which require prior authorization. Many insurance companies have created chat lines and member support lines. This is a period when a lot of them have stress, not only economic, the fear of COVID itself, and the depression when their family members and loved ones are going through this crisis. The next one is the availability of test centers. The insurance companies have posted on their website the areas where the test centers are available for their members. And as you all know, that most of the insurance companies have waived any copay or deductibles for these tests. The websites also have symptom checkers to help members who visit those websites to check for their symptoms and see if they need testing, or any member support chat line or member telephone support. So actually the website on Humana says all the frontline doctors, they deserve eternal gratitude. So I think all insurance companies realize the stakes that our doctors are putting themselves and their families into by being the frontline defense for this COVID attack. So they have also extended, many insurance companies, there is a provisional credentialing. So if you are seeing patients for United and you have not been credentialed before, you can use that opportunity of provisional credentialing during this crisis. It's for 60 days, I think they credential you. The next thing is, the Medicare is also doing the accelerated and advanced payments for those within 180 days of this COVID period. And also they have relaxed the requirements for nursing homes to bill for charges, and all the constraints that they previously had for transfer from one hospital to another. Those constraints have been removed because they want the beds available for COVID patients. The other thing the Medicare has done is, they have extended indefinitely the requirement for risk-adjusted, data validation that they usually did in April and August. So they have extended that. Okay, so with this, I think I would like to introduce Dr. Stewart. I joined Florida Blue in September, and Dr. Stewart has been instrumental in my joining Florida Blue. She's an excellent physician. She has been in practice for 35, she has been a physician for 35 years. She holds an MBA from Auburn University. She's very astute and very caring person. She joined Florida Blue in 2012. She was a medical director, and then she went on to become a regional medical director for care management in 2016. And she has for Medicare Advantage and commercials. And then in 2018, she has become the statewide care management senior medical director. She was previously the vice president of Hologic, which you know is the hyperbaric oxygen and wound healing centers. And she was also the chief medical officer for Brooks Health System, which is a rehab hospital in Jacksonville. She was an assistant professor of medicine at Medical College, Virginia, Richmond, Virginia. She has published a number of peer-reviewed articles. And above all, she is my very best friend at Florida Blue. With that, Dr. Stewart.
Thank you, Dr. Aaron. That was very kind. I just want to first start with thanking all of you for participating, but also for all the care that you're providing to the patients out there all over the country. So I think all of us really appreciate the work that you're doing and sometimes the risks that you're taking. So I just wanted to briefly give you some more information about how your insurance company, the patient's insurance company, can potentially help you in these difficult times with a lot of issues with patients. So most insurance companies, health insurance companies, have care management functions or case management functions. So one thing to think about if you're struggling with an issue with one of your patients is to consider reaching out to that insurance company and getting in touch with their care management department. At Florida Blue, which is one example of an insurance company's approach, we have physicians like myself, many nurses and social workers and pharmacists, a few dietitians, and some licensed clinical social workers that are all arrayed and ready to assist in whatever the patient or member issue is. So keep that in mind as you're facing these different challenges. You can have the patient call the number on the back of their insurance card and ask for a care manager, or you can help them do that. And the insurance company should be very helpful and try to engage and solve the problem. As Dr. Arun mentioned, at Florida Blue, which is one example of an insurance company, we have expanded very rapidly telemedicine. As the previous speaker mentioned, we have not been as quick with getting it out there as maybe we should have. It's been on our list and we've been working on it. But now with this emergency, we have expanded it, and you can use Zoom like we're using right now. FaceTime is also a possibility, but when you're using these non-secured technologies, then you need to let the patient know that you're not in a secure environment to have the conversation. The other thing that we did, as mentioned, is we've reduced and eliminated some of our pre-authorization type of requirements to make it easier for patients to move from one care setting to the next. And I think, as Dr. Arun mentioned, most insurance companies have information on their webpage about COVID. And I think ours happens to be particularly good. And so if you have questions or have a patient that needs information, direct them potentially to our website, floridablue.com, because at the very top of our web page is a banner where you can click, and there's even a chat box. So really excellent information, as I'm sure the other insurance companies have provided. So that was really all we wanted to talk about, was just to let you know that you have help out there with patients, and your insurance company, the health insurance companies, also have resources that can be very, very useful in these times. Thank you.
Great. Thank you so much, Deborah. And thanks, thanks, Arun. That was awesome. Actually, this is something which it's a great thing. Everybody's pitching in and helping out during this crisis, and that's this amazing thing. But what's happening here, that though Medicare has relaxed a lot of rules, you know, they're allowing actually non-HIPAA compliant video and audio recording or consultations. There are a few caveats which we should not drop our defenses. And here is where I want to introduce Dr. Rakesh Chandra and his son Siddharth Chandra to come in and explain to you guys that we are in this crisis mode, and we are obviously in almost a panic mode. And when we see that we've been given all this great help by our insurance companies, and we can do this, but there are some medical legal aspect that might come back and haunt you after this crisis is over. And I would like Dr. Chandra, both Dr. Chandras, to address this. Dr. Rakesh Chandra is an MD, JD, LLM. He does health law. He's a physician advisor for behavioral health sciences, Quorum Health Resources, Nashville, and also he works at Kentucky Medical College as professor of psychiatry. And his son is an associate medical director of their own company called RASIC Complete Recovery. He is an internal medicine and psychiatry board certified doctor. So Dr. Chandra, you guys can unmute, we'll unmute both of you, and you can start, all yours. Thank you.
Thank you very much, Amit. It's really nice to be here. Of course, I recognize a lot of familiar faces, but for the people who don't know me, because I was in API before your time, I'm much older than I look. I'm from AIMS in Delhi, and I did my internship at the University of Chicago in psychiatry, and completed my residency in Johns Hopkins in Baltimore. I have a JD and a LLM in health law from a program at Loyola Law School, and I spend a lot of my time doing legal consultation. Our main practice is, of course, a geropsych unit which we have, and inpatient and outpatient drug and alcohol rehab program. We also have a program where we help professionals who get into trouble with drug and alcohol problems and lose their license. As you all know, there's a diversion program that if you get into trouble and you want to preserve your license, instead of being subject to problems and having your license revoked, you can go into a diversion program and get help for your difficulties, and then of course get back to practicing. I'm proud to say, of course, like a proud father, that my son Siddharth Chandra joined me last year. Our company is called RASIC Complete Recovery, and we have a website which will put that out. Now, I wanted to talk about the medical legal aspects of COVID-19. And I believe one of the doctors just a short while ago said very clearly that we have to let our patients know that even though the rules have been relaxed, there are legal problems can still occur and have not been relaxed. And we can talk about a lot of issues with legal liability, but I'd just like to focus on a couple of them. One factor that you have to recognize is that HIPAA is still, just because Medicare or Blue Cross Blue Shield of Florida has relaxed their rules, but litigation has not relaxed its rules. You know, you still have to be very careful about what you are doing, because you could still be sued. I mean, just as a simple example, and I'm sure Dr. Amit can talk more about this, but suppose you have a patient who has a penile implant and you're talking about issues centering around that, and you're able to bill Medicare or Blue Cross or anyone, that's fine, but you still have to maintain confidentiality. And using a social platform, sometimes that information is not confidential. It can be accessed by a third party. You will still be liable. Your defense cannot be that you are because it was COVID-19, you will still be sued, and legally you will still have issues. We can talk about that more, but another factor which I wanted to talk about was that even though the scope of practice has been relaxed, and a lot of the states that we are in, and I can see that all of you are from different states, including us, we are from Kentucky and Illinois and so on, but there are Good Samaritan laws. And the reason I talk about that is recently we had a case here where someone who is a qualified licensed doctor, but he did a procedure which was way above and beyond his scope of practice and training. Now, his defense was that he's in a Good Samaritan state and he was the only doctor and they needed him to do something. But the fact of the matter is this, that you need to stay within the scope of what you've been able to do or you're required to do. For example, I'm a psychiatrist and I have someone with a severe head trauma or something. I'm the only doctor, there's no one else who can come in. But the Good Samaritan law will not protect you if you go way beyond your pay grade, in a sense. So you have to be careful. Again, something that Amit probably runs into regularly, it is things like they have allowed now that you can do elective surgery, but elective does not make it safe for the patient to be not exposed to COVID. And I'm sure that many of you who are surgeons run into this, that even if you allow the patient to give them the option, and you have to give them the option and they have to agree, but if something goes wrong, you have to be very clear that they were aware of the fact that it was a consent that they gave, that they could have refused, and they did not. So the point and the message I want you to take away is very simple. Rules have been relaxed, HIPAA has been relaxed, but you still can be sued and those suits can still prevail. So be very careful. Of course, do the right things, inform the patients, do exactly what you have to do, but keep in mind that relaxation of those rules does not relieve you of liability. Sid and I ran into a problem, and I think he wants to say a few words about something. We are psychiatrists. We were using a social platform. I think we were using a telephone call to talk to a patient, and I think we ran into some issues. Sid?
So, and thank you. Just to follow up on something that Dr. Rakesh Chandra was mentioning. So using a template is good, and especially in this time of COVID, you want to ensure that the patient is aware that even though elective surgeries have been resumed, that there is still a risk that if the patient comes to the hospital, they may be exposed in some form to either a patient with COVID, or there is a risk. So, you know, we can send a template, or we can create a template that expresses that the patient has been informed that even though the surgery is elective, it can still be postponed because we are in a time of crisis and there is the potential they can be exposed to COVID while they're in the hospital for an elective surgery. The other thing, you know, as we've been talking about a lot of telemedicine and televisits, is though the rules are relaxed, you have to be aware that you're now in an uncontrolled environment. There are other people in the room. Something that, in the case that my dad's referring to, is when another physician was discussing a sensitive topic with a patient on a video visit while the patient was at home, and the physician was unaware there were other people in the room. You know, a lot of us talk about very sensitive topics. For me and my father, we talk about mental health. For Dr. Amit, he talks about urology, and some of the other, you know, there are more sensitive topics: erectile dysfunction, sexual health, pregnancy, STDs. You have to, it is on you as the physician to ensure that the patient is in a safe, comfortable location where their privacy is ensured, and that there is no one else in the room. So just even a simple, like, you know, while you're starting the visit, saying, you know, are you in a safe environment? Is there anyone else in the room? There is a potential, we will talk about sensitive topics such as, and you can give examples that are related to your field where, you know, are you comfortable with there anybody who can hear you currently, or can hear your voice, or can see you, is okay with being exposed to this information, you know, especially in topics of mental health, or if you're a professional, any of these things can be very risky. And if there is someone in the room or someone nearby, that's a HIPAA violation, and you are liable for that. You know, and especially with older patients, a lot of older patients get younger ones to help them, set up the computer, set this up. I have had a patient who called for a telemedicine visit on video chat and was walking in the park. And I said, we are going to be talking about some sensitive topics. Are you sure you want to talk about this in public? And he immediately said, oh, no, I'll call at another time. Let's not do this. He says, my whole family is walking with me in the park. So just something to be cognizant of in this time of change. It's easy to slip by these topics and easy to forget, but the patients are not in controlled environments, and there are other people around that can pose risk, intentional or unintentional.
Thank you. Thank you. Yeah, just one word, Amit. I wanted to mention that we do have a fair population of people who have HIV, and of course, with the newer medicines and everything, they're doing well. And we are treating some of the psychological aspects because some of our dementia patients do show up with being HIV positive. We have to be very careful. That's another area where we want to be sensitive. And, we are doing an open forum. We're talking to them. You have to be very careful asking them that, hey, by the way, what was your CD4 count? Because we don't always have the immediate records in front of us. We have the psychiatric records, but we don't have the latest blood tests and workup and so on. Have to be very careful because this is information that they have not given to everybody. They have not shared with everyone, and there's a big risk. So just a word that, again, inform your patient that you're using an open forum. Remind them that that HIPAA does still apply. And as Dr. Sid said, be very sure that they understand that you'll be discussing sensitive topics. And from a medical legal point of view, you are still liable. And COVID or not, you will still lose the case if a liability issue is brought against you for violating confidential information.
Thank you so much. Thank you very much, Dr. Chandra. That's something which is not discussed in many of the forums, and I thought that bringing this to the public to be aware that we shouldn't let our defenses down even in this time is a very important topic. So I'm going to actually sum up by doing a base. Hello. Yeah, I'm going to talk about this a little. What we actually do these days, just to make sure that keep the light on, so to speak. So I've got a little slideshow which I'm going to project. Hang on one second. Okay. Here. Start screen. There you go. Okay. All right. Can you guys see my slides?
Yeah.
Yep.
Yeah. Okay. So basically, what we need to do, I've put a very small slideshow so that you guys. What we do is we, as physicians, we were faced with this big thing that whether we should stop seeing our patients or whether we should continue seeing our patients. That's a very, very big thing. I mean, now it's relaxing a little bit, but I'm talking 1 month ago or 1.5 months ago, we were in this dilemma of what to do. On one hand, we want to keep our light on. We want to serve our patients. Our Hippocratic Oath says that we have to serve our patients. We cannot shut ourselves at home and not give them the service. Yet we need to be, safe and make sure that we don't put ourselves or our employees at harm. Number two, we have to also think about the finances, especially of the employees. Before the PPP came around, we were very, very concerned about the employees getting their salary. So basically what we need to do is, I've divided this into about 4 or 5 slides. First thing is that you have to prepare your workplaces for a COVID-19 outbreak. You need to actually see how you can lower the impact of COVID-19 on your workplace. For doing that, there are 3 points: reduce transmission amongst employees, maintain healthy business operations, and maintain a healthy workflow. This is what we can, let me just, how can I do this smaller? So we have to develop a preparedness and response plan. We also to prepare basic infection prevention measures, which includes making sure that you have masks on. If the patient has any reason Most people actually give all the patients a mask. All patients get a temperature checked. We don't allow any visitors to come with the patient to the room. A lot of times we have the patients sign in and go and sit outside or in their cars till their turn comes and we call them. So these are a few policies and procedures. We have our receptionist call every patient, ask them if they are suffering from any of the symptoms or have they come in contact with anybody who has come suffering from the symptoms, and tell them that please reschedule or get better and contact your primary care physician or whatever needs to be done. But most importantly, tell them that we'll not charge you your no-show cost, because we have a policy that if you don't cancel within 24 to 48 hours, whatever you charge a no-show fee, we actually waive those fees. So those things also can also help, and those are things which will make patients actually think twice about coming. Some people may just come because they don't want to pay that no-show fee. Workplace controls, you need to make sure that if your employee feels that he or she has come in contact with somebody or has a family member who has that, you need to make you need to make sure that he or she is aware of how to prevent exposure. Take that additional steps. Essentially, you should follow the existing OSHA standards, which is there in this little clip, which will be there. You can always check this out, osha.gov. And so now what also you can do is you should encourage your sick employees to stay at home. You modify your sick leave policies. For example, if you have a policy and a patient doesn't have any sick leave, maybe you should change that policy and tell them that, oh, you can take your time off and you can make it up when things get better, and we can do that. For higher risk employees, for example, anybody who has other comorbid factors, bad diabetic, or he or she is elderly, you might like them to actually stay at home and not come, and tell them, hey, we'll pay you or whatever it is, because the payment protection plan actually will help offset some of those causes. We need to separate sick employees, maintain confidentiality. Also, don't tell everybody that, hey, she's sick, that's why she's not here. You should not be, you should not do that. Medical legal aspects are there. Plus, the patients or the employees may not just like it. And obviously, educate the patients or employees how they can reduce the spread of COVID. Talk to them about hand washing, masks, social distancing, all of them. I mean, most of them know that because it's absolutely repeated ad nauseum on TV. So most of them know it. But most importantly, please do not inject Lysol into you. Then, to maintain a healthy business operation, it's a good idea if you've got a big office, more than, I don't have such a big office, but if you've got a big office, you should identify one person who should be the workplace coordinator for COVID-19, that period of time. She is the person who's the go-to person who will tell you what to do and what not to do. And she'll be your monitor, so to speak, to make sure everything goes. And as I said, you implement a flexible sick leave policy. You assess your essential functions. Tell the patients who are not essential, they don't need to come in. They can actually postpone their visit. For example, if it's just a PSA, they can get it done a month later, or you can do it over telemedicine. Also, you should determine how you'll operate if this absenteeism spikes. For example, if you have both your secretaries who are sick or who have to be gone, how do you operate during that time? Well, you have to cross-train. Your office manager may have to step in and work as a receptionist or your medical assistant. So you need to have that backup plan. And also in your office, in my office, I have got my waiting room area. I keep chairs 6 feet apart, and I've got the privilege of having a private corridor. So I put the chairs 6 feet apart in the corridor. So most of the people who even come who cannot go back to the cars, we tell them to sit outside and be 6 feet apart. And lastly, the environment, if you can do it, if it is bigger office, you should talk about ventilation system, respiratory etiquette, hand washing, make sure they don't cough, and you perform the routine environmental cleaning and disinfection every hour. After every patient, my rooms are washed or actually wiped down with bleach, and every hour we wipe down all the doorknobs, any hard surfaces, any plastic surfaces, we clean it up. So we need to enhance the cleaning. If there is a patient who is really COVID positive or is suspected to be COVID positive, you need to double up on these things what you do. And when you have employees, tell them that, hey, now the travel restrictions are being relaxed a little bit. Tell them that if they are going out, please be cognizant of the fact that it is your defenses not dropped, that social distancing, the masks, if you go to the grocery store, you should do that, because if you get sick, the whole office can close down. So that responsibility should be given to them. Surgery guidelines, you should make sure you follow your society and hospital guidelines, otherwise you may be liable. And I say both ways. This is the last slide. Both ways meaning, if you have a patient who needs surgery, let's say, and you say, no, I cannot do surgery because of COVID, and the hospital says, no, you can do, and your society guideline says that, no, you can do elective surgery, he or she may sue you for keeping a patient with a stone and not operating. On the other hand, if the patient has, a hospital allows elective surgery, like Dr. Chandra has, you need to make sure that they know that they know that it is their decision whether they want to be operated during this time or do they want to postpone their treatment till later. That is an additional informed consent which I have added on, and you guys like to try to add. Avoid elective surgery on high-risk patients, especially if you think they'll need ICU space or ventilator, because you want to keep your ventilator and ICU space free for the people who may need it due to COVID, because the risk is not completely gone yet. All elective surgery patients in my hospital, I'm sure majority of hospitals, even when elective surgery starts, have got to get their rapid testing done for COVID before being allowed, and they are not allowing any visitors. But you still need to take additional precautions. What you need to do, just to do that additional face mask. Previously, when I used to do cysto, I never wore a mask. Nowadays, for cysto also, I wear a mask, and you need to take additional precautions. Thank you very much. And what I'll do is I'll stop here, and I would ask you to put in the chat box, put your name. And a lot of people also are doing this. When COVID first started, my nurse practitioner is a little bit more cavalier, and she wears her mask and everything like that, but keeps 6 feet away. She used to actually go to the room and telemedicine me with her cell phone from the room with me, but we have dropped that. I keep my patients 6 feet away if I can, unless I'm examining them. And I try to hold my breath when I'm examining, but we keep them away. We wear masks and make sure that we try to limit our visits to essential patients, try to do most with telemedicine. So do you guys have any, I'm going to open the floor for questions. Questions for the, I'll ask a question for the attorney. What do you foresee our liability as an employer? For example, if an employee gets sick and the employee's mom passes away from COVID, what is the liability there?
Amit, actually, that is a very good case. In fact, in Illinois today, we had this case happen, and the whole question of workman's compensation, working in a doctor's office, getting it themselves and passing it on to their family, is an area which has not been settled. But clearly, the law is that if someone gets ill in your office, then make sure it is your responsibility that they are isolated and don't give it to their family, because there will be a liability issue. And I'm not clear, and the law is not clear as to what exact path that will take, but it will be an issue that's going to be litigated, because we have our first case here in Illinois where exactly that happened. And they're trying to understand, is it a tort case, like a malpractice case, or is it a workman's compensation case? So it's uncharted territory. We've never had this before, and we don't have any legal precedent for that. But there will be consequences, so you have to be very careful that A, your employee is safe, which is, of course, under workman's compensation. But the fact that if your employee gets something and takes it and gives it to their spouse or their children. So what we have done, and one of our nurses is doing, who works very closely as the coordinator for the COVID program, she actually stays at a hotel and she does not visit the family. When she does, she takes all sorts of precautions. They meet over the weekend. There's all kinds of precautions as if she's with a patient, because she's very concerned about passing it on to her family. So it's uncharted legal area, workman's compensation, tort law, but there will be liability issues.
Good. I think the next, a few other questions. One is that medication requests from pharmacies can be billed. Sanjay has asked that. Yes, you can do that. Lot of these calls are, if they're patient-initiated calls. I'm not absolutely sure whether it's pharmacy-initiated calls can be billed, but Sanjay thinks that is the case. I'll ask that question to Dr. Arun and Deborah, and also there's one more question for Blue Cross. I know that for Medicare you put 95 modifier, and that's the only thing you need to put when you bill your office visits. But for Blue Cross Blue Shield, does Blue Cross Blue Shield need a place of service 2 instead of place of service 11? So can you answer that, Dr. Arun or Dr. Deborah?
Please.
Dr. Arun?
Hi.
Did you get that question?
Yes, I did. Yeah, thanks. So
Speak a little louder.
Yeah. Most of, I think we have relaxed the telemedicine and even the telephone consult. For example, the first thing I want to say is, we forgot to say this at the beginning, both myself and Dr. Stewart are representing the views that we have with all insurance companies. So Florida Blue is not liable in any way for our opinions. So I want to make that clear. And one of the things that we were looking at is that 65% of the patients, we have national statistics on what's going on with the member community and the physicians community. 65%, when they took the survey of all the physician practices, they said 65% of patients cannot even use telehealth or internet services. So this is the big constraint and the big challenge. However, when the patient or the physician get into a dialogue about test results or about any form of care, they can bill that and claim the telehealth consultation. And we have also, I think some of the insurance companies also allow the telephone consult because of the video and computer constraints for some of those members. Most of the members have a telephone. Regarding the modifier, I'm not sure. I'm sorry, I defer to Dr. Stewart if she can answer that question, but I don't know the answer to that question.
Yes, thank you. Thank you, Dr. Arun. And it was good to make that comment that we're just representing ourselves and not Florida Blue. I believe the modifier is 02, but neither Dr. Arun nor I are coding experts. So on our webpage for our providers, that kind of information is provided. So it's my recollection that you put the modifier 02, but don't take my word for it. Look at the insurance company's webpage that provides information for providers to get that detail. Thank you.
And I think Dr. Murray Shetty can answer that question. Maybe Dr. Murray Shetty can, or Dr. Grover can answer that question about the modifier. I think he has a set of codes, Dr. Murray Shetty said. Can't hear you, Amit. You're on mute.
Okay, you're unmuted. Can you hear me?
Yes.
There you go.
Okay, Dr. Morissetti, are you still there? Okay, can
Yeah,
you?
I'm here, I'm here. Can
did
you hear
you
me?
did you find that? Did you find the that slide which gives you a code? Did you find that
Yes, I
slide?
did.
Okay, can you
Yes, I
see?
did.
Can you put that on your screen? Because a lot of people want that slide. And let me also tell you that I have got a nice little form which has all those codes, and I'm going to put it on WhatsApp groups. And please get it from there. If you don't get it from the WhatsApp group, if you don't get it from the WhatsApp group, email me and I'll send it to you. Okay, good. Go ahead. Dr. Morissetti, go ahead. Your thing. আমার ফেসটা এখানে আসবে না এক্ষুনি এসে গেছিল তো আমি সেটা বলি তোমার বললাম সেই জন্য তুমি ফটো একটা ক্যামেরা নিয়ে না আমি এখন আনমিউট করে দিয়েছি
Can you hear me now?
Yeah, we can hear you, but we cannot see your slide. The question which somebody raised that for Blue Cross, Dr. Morissetti, the question which was raised is for Blue Cross Blue Shield, do you have to change the pace of service to 2 rather than 11? Because I was told that right now all Blue Cross Blue Shield and private insurances are mirroring whatever code Medicare is allowing. As far as I know, that's what I've been told. Okay, and I've got people on the chat. Dr. Morissetti, somebody has a background noise. Okay. Can you mute everybody except for me while Dr. Morissetti is setting the slide up? Can you make me the Vijaya, can you make? Okay. Yeah. While Dr. Morissetti is getting the main picture, put my slide as the main slide. Let me ask a few more questions. So somebody has this some kind of air going in the background. Somebody can you just mute yourself? Whoever has the air in the background. Dr. Morissetti, mute yourself for a second till you get the slide, okay? Can you mute yourself till you get the slide up? Okay, good. So, yes, I have got people, there is one person, I've got Dr. Kakani says that, yes, they have been billing with 95 modifier and Blue Cross Blue Shield and Medicare, both of them are paying. And also there was a question, is Blue Cross Blue Shield paying for a telephone visit as an office visit? As far as I know, it's not. Dr. Arun just now said that they are allowing telephone visits, but that is one thing. I'll come back to that because there is a couple of questions for the financial, Dr. Nilagaru. So Arun, please, one question is, please, I'll come back to the question or if you can give me a quick one sentence answer if you have it, that whether Blue Cross Blue Shield is paying for a telephone visit as a full office visit. You said things have been relaxed. Can you just let me know for a second? There you go. Hang on, before okay, Arun, go ahead and give that answer.
Very quickly, I don't think they're considering that as an office visit. You can bill as a telephone consult.
That's what I thought, yes. Okay, Dr. Morissetti, he has this CPT course on here, and if you can scroll down, this is the regular visits, 421, 422, 441. So the ones which we are actually, I mean, we don't do online digital E&M service, so that 422, 421 is not that much for us, I think. More importantly is that 441 to 443, and then we have the regular E&M code for video calls. Dr. Borishetty?
Yeah. So those people who are engaged in chat, I disconnected chatting service because there are going to be so many messages and they expect a call right back, which we cannot do. So I disconnected that, and it is this 7-day rule. So all these billing criteria rules, if you can see, I don't know if you can see my arrow, are all suspended right now. These rules that were put in by during this emergency, but otherwise these rules apply. All these rules that I have put in there in billing criteria. So these codes, and I put in some WRVUs because those people who get paid by RVUs, you want to know, is it worth doing something? You know, if you do the service and the company gets paid and you don't get paid or you don't get credited, I put in some WRVUs here too on the same sheet. The key difference between third-party payers or non-Medicare payers right now during this period is there are three different telephone calls which are not video calls. Is 5 to 10 minutes, 11 to 20 minutes, 21 to 30 minutes, and then your RVUs are pretty decent, 0.75 on an average. You will take at least 30 minutes anyway. If nobody hangs up in 10 minutes with any of my patients, Medicare patients. They are not limited, but they got, once you're on the so mine are about 0.75 WRVUs. On an average $50, $60 RVU, you're getting 40, 50 bucks. That's not bad for a half-an-hour phone call. So, and then when we go down to the digital, they actually have decent RVUs. 0.8 RVUs is for 21 minutes in 7 days. So if you are back and forth within 7 days of back and forth communication, you can build these chatting services or email services that you can use. Then they were asking about G codes and all that. G codes are mainly hospital-based codes, and in our hospital, in our program, we do use different codes. Somebody was asking what's the difference between a place of service 11 and place of service 2. Here is what I'm showing. In G2012, you use 11, but in G2010 and other codes, you have to use place of service 02. And all the documentation requirements are on the right side here. Documented verbal patient consent is very, very important. Everyone has to have this already a macro sentence that is already there. You click it in, it is there in the documentation. And
I put that what I have I use in my office. I put that in the chat. Please scroll up, and there's one how you start with and one with the note at the end. I've already put that. Go ahead. Sorry.
And then this is a slide that my manager prepared actually for nursing home. Somebody was asking. So nursing home visits can be used as a televisits too, and then you can, pretty much do visits there. And then these are the CPT codes for the telehealth crosswalk, CPT code for GT modifiers, how you can modify them. If somebody wants, they can look at this. These are all the nursing home codes, annual nursing home visits, and different levels of nursing home visits, that how you can bill for televisits. And here is another slide where again pointed out place of service. These are different insurances, their requirements I have put in our region in Pittsburgh market. Here, these are our major insurers where their criteria are put together. Aetna, Anthem, Cigna, Humana, Medicaid, Medicare, you got United and UPMC or local West Virginia Medicaid. So these are all the guidelines, the requirements each insurance company requires. And this is one thing you got to do if you have non-Medicare patients, you got to follow these guidelines. So having this chart for your staff or billing coordinator in your office is important, because I have a scribe and she knows all these. So she's in the room with me, whether in a televisit or in my physical visit, she's always with me. She makes sure all these points are covered. My piece will be 1 or 2 sentences that I important want to cover in my plan and my assessment. Rest of the things, my scribe takes care of all these guidelines that she knows all these charts. Every insurance she looks at what they require, she makes sure all those are documented so we get covered. And my scribe is very useful in these kind of services.
Great.
Phone calls, my scribe is not there, so those I document myself.
So,
Telephone calls, I will always try to do video calls.
So, Dr. Morissetti, this slide, these all these code things. I will talk to Suresh and Sudhakar and other people in API and see how we can get this codes out to. This slide is very important. See if you can get these slides to people. This is the flow sheet he was talking about. It's excellent flow sheet, but we will see if we can send it via our telephone call next time, and we'll do that. So so anyway, I've got a question for Dr. Nilagaru. So a question is that should we open a separate account and then put the PPP money in that account? And when we run the payroll in June, do we reimburse our operating account from the PPP account?
Yes, the answer is yes. Have a segregated account and plan how we are going to use those funds in the next 60 days. And then you can transfer those points to your own business account and then distribute your funds the way you want to do it, including the payroll and all the other things.
Yeah, so basically, yeah, go ahead.
Brian, you want to add?
No, I think that was a good description of what to do if you keep the money segregated into a specific account so that you find it very easy to be able to manage the process. You know, the other part is that you have 8 weeks to spend the money from the day you get it. You have to take the money within 10 days of getting the loan approved, and you have 8 weeks to spend the money. So you need to be very attentive to those dates.
Yeah, so like I said, we got that very in the first week because I was in a small place in a local bank here, and we got the PPP, and we didn't really know what to do because initially they had allowed the 1099 workers to be included, and then soon after that on April 2nd, they took the 1099 workers out. And you can just mention a little bit because there have been questions about 1099 workers in the blog, which I sent email everybody. I've gotten calls. Just address a little bit about what people should do about the 1099. I know it's still work in progress, still fluid with my discussion with Dr. Nilagaru, but if you can just shed some light about what should we do for 1099 workers? Like 1099 is part-time workers. Yeah, go ahead.
Right, for 1099 workers, you need to have completed your Schedule C, which is your business part of your return, and the amount of money is based on the net income that you have earned, average per month over the last year. One of the big challenges is the multiplier is 2.5 times. The big risk for the banking system is we're required to calculate that number accurately. A lot of banks are very concerned to sometimes only use a 2 times multiplier because of the nature of self-employment income and that people's documentation sometimes not being as deep. The other part is we're requiring that people already have filed their 2019 tax return, because as a bank, we're concerned that just because somebody has calculated what their Schedule C is going to look like, that doesn't mean that is what they're actually going to file with the IRS. So that creates a higher level of risk for the bank. I think most banks have been looking at the whole issue of 1099 income and how to do the PPP program with a lot of trepidation.
That's great to know. So basically, just for what I understand, that you got to have your same employees still here. We had one employee who decided not to come back because she was getting more money because of the stimulus package. She was getting more money. That you can always tell your bank that this employee decided to move on or not come back or something like that. And that was one thing. The other thing is that there's one thing also you need to know, that you can give everybody a raise. Make sure the raise doesn't raise a red flag, but you can give yourself actually a little raise and any of the other employees. In other words, if you've got PPP money, which is a little bit excess and you don't want to give it back, you can give yourself a raise. 25% of the PPP money can be used for utilities and your mortgage, office mortgage, rent or whatever it is, for non-payroll purposes. 25% can be used for that, and the rest 75% has to be used for payroll only. So
yeah, you know, that is correct. Two things I want to point out though is when you make application, the bank actually inputs the information to SBA as to how much of the money you're going to be using for employees versus non-employee costs. So if you told your bank that you were going to use 100% of your costs for only employees, then using it for other things may or may not be an issue. We honestly don't know yet because the forgiveness part of the loan and all of the regulations associated with that have not been issued yet. So you're flying a little bit blind on that part. The other thing is that you, back to the employees, you can have none of your previous employees come back. That's not as much the issue. You need to maintain the same number of FTEs, full-time equivalents. So if you had, you know, Bob, Carol, and Nancy, and they didn't come back, but, you know, Billy, Suresh, and Susie came, and they create the same level of full-time equivalents, you're covered.
I have a question from you, Mr. Cohen. The money that you get, is tax deducted at source?
That money is actually, from what the initial guidelines are, it is a completely forgiven loan.
Okay.
Acts as a grant, and it is not. There is no tax impact on you at all. It's as though you never received the money at all.
I understand, but the question I have is that when you calculate the amount, the 2.5, is it on your after-tax income, or is it on your, you know, tax paid?
Oh, for a 1099, it's on your after tax, and again, the cap is $100,000 of income.
Right.
So the most amount of a loan / grant you could receive is slightly over $20,000.
Perfect. Thank you.
And if I understand correctly, also, Brian, one more thing which I've been told that you know, the payroll, if you by any chance do not use the whole payroll, it is you can return it at a 1% interest rate. Initially, it was 0.5%. Now they've increased to 1%. So in other words, you can still consider that as a loan if you do not utilize the whole thing as PPP. Can you clarify that for me, please?
You are 100% correct, and you are taking a loan. So if after 56 days you've the 8 weeks, you've determined that you have not used all the money, you can hold on to the money, and it is a loan that goes for a 2-year term and then needs to be paid back. Or just like any other loan, you can pay it back at the time that you determine that you didn't use all of the money. There is no prepayment penalty to you.
Great. So there's another question which comes from, it says, my employees have taken furlough because they get paid more for unemployment of CARES program than what I pay. During forgiveness, how do we fulfill that requirement? Forgiveness loan is considered an income. And I think we've partly answered that. If that happens, you are required to repay it, but only at a rate of 1% interest.
Right.
The other thing is that another question was actually not question, another comment is people who do sleep studies, they can do sleep studies from home and do televisits for compliance of CPAP evaluations, etc. So, you know, they can upload their CPAP thing online and they can actually bill for that, as far as I know. So another question here is, there was some questions selecting to acute stroke, but I think that was only for people who are neuro-hospitalists, and there was a specific code. I don't, okay, there's one more thing. If an independent contractor has not filed, if an independent contractor has not filed 2019 taxes, they can't apply, or bank can see, or bank can see Schedule C to be filled and determine that 8 weeks. You have to spend the money within that 8 weeks from the time we got the loan. Yeah, and that has been answered right now by Brian. I think that's exactly right.
Yeah.
8 weeks to give
8 weeks. And again, we at Quantum, we have decided we will not make a loan if somebody has not filed their tax return. There may be another bank that would make the loan if somebody hadn't filed the tax return. The issue is whatever you are preparing has to exactly be what is filed to the IRS. And we only know if it's filed correctly if we actually have a tax return.
Amit, I have a point to make.
Yes.
The time is of the essence because the gates are going to open by the SBA on Monday at 10:30. If you have not applied, make sure you have all your documents ready before the time, because we feel the money will be over within 1 to 5 days. My personal feeling is it will go over in 2 days. So time is of the essence, and please get on it. And if you need what documents you need, or if you want to apply to our bank, if you are within 2-3 hours of Atlanta, go to ppp@quantumbank.com. It will give you all the things that you need to do to apply with us or with your bank. And that's very important. And make sure that you do not apply with multiple banks. That leads to confusion, and your application may be kicked out, and on and on, so it's a problem. So also I want to stress that please have a segregated account once you get the money. Thank you.
And also something else which was not covered a little bit in detail, that in addition to this, Medicare is giving that a stimulus, government is giving us a stimulus package, which is about 6% of your past Medicare billing in the last year. And that goes to hospitals and physicians. And this is the money you don't have to apply for. It comes automatically to you. It's HHS stimulus package. And I have got that. It's a 6% of your previous year's Medicare billing. And that's something which you can look out for. Unfortunately, there's nowhere to apply for. All you need to do is to go to the HHS website and find out a little bit more about it. Do the 8 weeks start from the time we receive the money? Yes, that's been answered. The time when you receive the money, that's when their 8-week window starts. Again, a little on a funny note, Dr. Nilaguru and Dr. and Brian, this is that next life I want to be a banker. I love the locations where bankers are. You know, your background location they're talking about. Anyway, that was a little side comment. I also have a little side comment about this. There's a patient of mine who came to me and he demanded, because at the time only urgent surgeries were being done in the hospital, and he wanted a penile prosthesis, and he said that this is urgent for me, and I had to actually I couldn't convince the hospital administration of that. All right, so I think our questions are kind of coming down right now, and we are actually we are about 10 minutes over, I think. Does anybody else? I'm talking to the Zoom chat group. If anybody else has any questions, just go ahead and write that. Otherwise, I'll ask if Suresh and Sudhakar, if you guys are online, if you could please give a closing comments, both of you, and Anupama, if you're there too, if you can give us a closing comments, please let us know how we did. And thank you for all your comments on group chat. And that is the shot in our arms. Everybody worked very hard. We did dry runs and stuff like that. And there was a quick question before we end. How about the new 20 billion allocated today? Yeah, that's what they talked about. Please go ahead and apply right away. I don't know whether this 20 billion is a separate from that the thing or not. Accelerated and advanced program from CMS. So a quick answer, Brian, before Anupama starts. Brian and Dr. Nilagaru, can you just tell us, there's another 20 billion allocated today. Is it in addition to what was already given? And is it the PPP money, or what money is that? Do you guys know?
Yeah, so the initial was 349 billion. This is another 250 billion. The other part about this 250 billion is it's in specific tranches for small banks, medium banks, large banks, minorities, underserved. And we don't have all the details on how they're going to track those different pieces, but the total amount is 250 billion.
Great. All right, so we could go on and on. This is a very, very hot topic, and very, I mean, this is basically the bottom line. We'd love to be educated on the medical aspect of COVID, which is very important. But this is something which keep the lights on in our office and keep your employees employed. And this is a big part of it. I'm glad that everybody enjoyed it. And please feel free to send comments to me at amitcmd@yahoo.com or to the RP executive. Anupama, please go ahead.
Thank you, Amit. It was a very informational session, and a lot of things I learned today, actually. And thanks for the viewers, and thanks to the speakers who gave your time. And hopefully we'll have one more session ongoing next time. Thanks.
Sudhakar? Are you there? Sudhakar? If Sudhakar is not there, then can you have Suresh give the closing comments?
Yeah, thank you, Amit. Thank you, Amit, for a wonderful discussion and putting everything together. You never let me down when I entrust you with something. I'm very proud of you.
Thank you.
And I just want to thank all the speakers, especially Dr. Nilagaru, Dr. Arun, Dr. Deborah Stewart, Dr. Satyasagar Morisetti, Dr. Rakesh Chandra, Dr. Siddharth Chandra, and the CEOs, Mr. Brian Cohen and Mr. Raj Grover. And we would like to do this another session maybe in a month or so when things get little bit clearer in this murky waters, and hopefully looking forward to hearing from you again. Thank you so much. Thank you, Amit. A great job.
Thanks very much. Thank you very much. And if you want any further questions regarding this, I put my email on the chat. It is amitcmd@yahoo.com. Just shoot me an email. I'll try to send you anything. If you guys want a copy of the codes which Dr. Morisetti did, I've also got a little document which has got the codes which we use most often. I'll be glad to send you the codes. So just shoot an email to me at amitcmd@yahoo.com. Thank you so much. Appreciate it.
Thank you, everybody.
Bye.
Thank you.
Thank you.
Bye.
Bye. Thank you, Amit. It was very nice.
Thank you, guys.
Thanks for